All right, here we are back with part 2 of chapter 37. And in this chapter, we're talking about abdominal and genitourinary trauma. We talked about we did a review and discussed some things to be aware of specific to abdominal and genitourinary trauma and what organ systems are involved in that. So now let's go ahead and dive into our patient assessment side of things. Of course, whenever we're doing a scene size up, top priority is the safety of you and your team, and then your patient, and then bystanders, kind of in that order. Both penetrating and blunt trauma are caused by an external force. So we want to make sure that that external force that caused this trauma is still not a threat to us. So we want to make sure that the scene is safe, and then try to make a determination of what the cause of this was, and if there's any other interventions that need to take place. So determine which patients need the most care and attention. So we're going to use that ABCDE method as we're doing our primary survey as well. If there's any life-threatening bleeding or cardiac arrest, we're gonna use the CABDE. We're going to start with circulation, and we're going to work that way. So if we see anything obvious, any obvious bleeding, or the patient's in cardiac arrest and they're viable, we're going to start with dealing with circulation, and then we'll move on to airway, breathing, and all those kinds of things. But otherwise, if they're conscious, we'll use the ABCDE method. And there's no life-threatening bleeding, we'll use that method. And along the way, we're going to make sure that we're determining which patients need the most care and attention and the most rapid transport. So that's going to be a big priority. So as you approach the patient, take note of how they are lying. Are they lying on their side? Are they lying face down? Those kinds of things will be an indication of what kind of mental condition that they're in, or whether they're even conscious at all. Movement can irritate the inflamed peritoneum and cause more pain. So the patient may lie still with their knees drawn up and breathe rapidly and shallowly because they're trying to keep from moving their abdominal cavity or using that diaphragm at all. The patient may also present with guarding, which is that involuntary tension of the abdominal muscles where they're holding everything up tight because they're trying to protect it from hurting any more than it already does. Remember that quiet, still patients are most likely to have some of the more severe injuries, especially when we're talking about abdominal injuries. You must determine if the patient has any altered mental status or signs of airway compromise. Those are still going to be a priority. The crucial step is to keep the airway clear of vomit and any kind of risk of aspiration. To clear the airway, turn the patient on their side while maintaining spinal precautions, and clear any material from the throat and mouth. Be sure to note the nature or type of any kind of vomitus that you do encounter. You should also assess the patient for adequate breathing, since a distended abdomen or pain may prevent them from inhaling properly. If respirations are shallow, you'll need to supplement their breathing with a bag mask device. Man, that's a tongue twister for me every time. So while superficial abdominal injuries don't usually cause significant external bleeding, internal bleeding from both open and closed injuries can be profound. Trauma to the kidney, liver, spleen can cause particularly significant life-threatening internal bleeding. So it is critical to cover wounds and control bleeding as quickly as possible, but keep a keen eye out and be wary of the possibility that there may be some internal bleeding or some internal injuries that we're not fully aware of. When caring for a potential genitourinary emergency, remember that this system can be a significant source of bleeding. So be sure to check for circulatory problems or shock, and don't wait until some of those more detrimental signs show up before you are moving things in the right direction for considering internal bleeding or that type of bleeding that you may not be readily evident. Remember that closed injuries do not have any visible signs of bleeding. Your patient assessment is going to be what will tell you how aggressively you need to treat that patient. So as you remove the patient's clothing, look for any presence of blood and inspect those areas more closely during your physical exam. Patients with abdominal injuries require a short on-scene time and transport to the hospital, especially if you suspect internal injuries that are going to require surgery, as their condition may become unstable very quickly. These patients should be evaluated at the highest level of trauma center available, which is indicated for those with a high suspicion mechanism of injury or visible signs of trauma. So remember, on your suspicion of mechanism of injury or visible signs of trauma alone, you can send them to the highest level trauma center. When considering a lower level of care, always follow your local protocols. Patients with genitourinary system injury should be taken to a trauma center, if at all possible, since their treatment may require specialized care. It often does, and the smaller facilities typically don't have those specialists available, and it oftentimes just prolongs the definitive care that the patients need. You should obtain as much or as many details about the injury as possible, but always remember that trauma patients need to be transported quickly, more so than we need to gather information. You may need to get information from witnesses, police, other EMS providers. Be sure to obtain a sample history from the patient, or at least as much as you can. When a patient's blunt trauma is from a motor vehicle crash, be sure to gather the following information while as soon as you can, ideally before you leave the scene. The types of vehicles involved and the speed of travel, how the vehicles collided, meaning was it a frontal, lateral, side, rear, whatever impact, and any other crash details such as the use of seat belts, airbags deploying, the patient's position in the vehicle, front seat, back seat, passenger, wherever. If there were any deaths or serious injuries to other occupants in the same vehicle, those are all going to be significant things that the hospital will want to know about. If a patient has sustained penetrating trauma, it is important to identify the type of weapon used whenever possible. In the case of a firearm, try to determine the weapon's caliber, the location of all the bullet wounds, and the distance the shots were fired from. If a patient has stab wounds, you should determine the type of knife used, the angle of entry, the number of stab wounds, maybe even the depth, width of that particular knife will be really helpful when they arrive at the trauma center. When performing a secondary assessment, remember that a head injury or the presence of intoxicants can mask the signs of shock from abdominal trauma. Internal bleeding or internal abdominal bleeding may not be immediately obvious from an abdominal exam alone. Remember, some of the signs of injuries to the abdomen may be slow in developing. So that's why it's really important to look at the other signs and a good set of vital signs and being hypercritical of those so that you can determine whether or not your patient does have some internal bleeding going on that you can't see. Suspect peritonitis if a patient complains of abdominal pain or if you find tenderness upon palpation or percussion, as well as if there's some guarding, rigidity, or distension noted. Be sure to examine the patient's neck and chest, checking for symmetry and the absence of breath sounds. Signs and symptoms of diaphragmatic rupture can include abdominal pain, acute respiratory distress, decreased breath sounds, abdominal sounds in the chest cavity, subcutaneous emphysema, and an abdomen that appears sunken or empty because the organs have made their way into the chest cavity. Inspect the patient's abdomen for abrasions, bruising, distension, or even obvious external bleeding, any kinds of wounds, eviscerations, or impaled objects. Remember that a complete inspection of the abdomen also includes looking at the patient's back. An abdominal wall contusion or bruise is usually easy to identify, and while not a critical finding in and of itself, it can be a valuable clue that significant blunt forces was applied to the underlying structures that could possibly be leading to hemorrhagic shock. Carefully palpate the entire abdomen, beginning with the quadrant that is farthest away from the injury. And as you palpate, be sure to note the patient's response and check for any abdominal masses or deformities. Remember that retroperitoneal hemorrhage may be present even if there are no obvious signs of external signs that there is an internal injury. Always maintain a professional presence when assessing and treating genitourinary injuries. You should note whether the patient has hematuria, blood in the urine, which is a sign of injury to the kidneys or the urinary tract. The color of the urine can help you determine the source of bleeding. Dark brown urine suggests bleeding in the upper urinary tract, while bright red suggests that the bleeding is closer to the exit. Traumatic injuries can be made worse by pregnancy, and the risk of massive blood loss increases significantly. Patient management should begin with the ABCDEs. Pregnant patients have a higher risk of aspiration due to the increased gastric acidity, and they also have a reduced physiological reserve. So it's important to provide maximum oxygenation to our pregnant patients. For patients more than 20 weeks gestation, tilt them at least 15 degrees to the left to relieve uterine pressure on the inferior vena cava and prevent supine hypotension syndrome. New technologies are proving to be very useful in the pre-hospital setting. For example, portable ultrasound machines are becoming much more common, such as the fast ultrasound. They can help decrease on-site scene time, treatment cost, and the patient's length of hospital stays. There's also telemedicine that allows physicians to remote into areas to receive and review images and diagnostic data from rural EMS providers. When assessing a patient's pain, be sure to use the OPQRST mnemonic and ask them to rate the severity on a scale. Somatic pain comes from the skin, muscles, joints, ligaments, and tendons. It is typically a sharp pain that localizes to the area of the injury. This type of pain is also usually accompanied by bleeding, swelling, cramping, and it often responds well to opioids and NSAIDs. Visceral pain, on the other hand, comes from organs inside the body, and they can travel from nerve pain receptors to the brain, and they can radiate to other locations of the body as well. It is often a deep aching pain with cramping and is felt in the thorax, abdomen, and pelvis. Opioids are typically the most effective treatment for this kind of pain because NSAIDs are less effective. And then, of course, reassessment is going to involve repeating the primary assessment, retaking vital signs, checking on the effectiveness of our interventions. Your field documentation is going to include things like whether or not seatbelts were worn, location, intensity, and quality of the pain, whether the pain is the patient is experiencing nausea and vomiting, the contour of the abdomen, any bruising, ecchymosis, or open wounds found on inspection, the presence or absence of rebound tenderness or guarding, rigidity, spasms, or even localized pain. Those are going to be all the things that we want to make sure that we document, and we document well. Document any changes in the patient's level of consciousness and serial vital signs. Be sure to note any other injuries you find. Document the presence or absence of alcohol, narcotics, or analgesics when you suspect those have come into play, and record the results of your reassessment findings as well. All right, so let's dive into some of the emergency medical care. I'm going to talk about some of the things that we're going to encounter and specifically how we're going to deal with those things. So when we're talking about our protocols and transport decisions, things such as that, critical findings during your primary survey, such as unexplained shock or physical signs of a significant abdominal injury, is going to necessitate rapid transport to a facility with immediate surgical capabilities. Pay careful attention to the patient's ABCs. Since hemorrhagic shock is the major cause of death and complications in abdominal trauma, you must begin shock resuscitation immediately and continue it during transport. Resuscitation usually consists of establishing 2 large bore IVs and administering IV fluids such as lactated ringers or normal saline. Your goal is to maintain a systolic blood pressure between 80 and 90 millimeters of mercury, and you should never delay transport to initiate IV therapy. Apply pressure dressings to minimize external bleeding, and apply a cardiac monitor, pulse ox, capnography, and transport the patient to a hospital or trauma center that is capable of immediate surgical interventions. Administering pain medications to a trauma patient is still a bit controversial because it can mask the symptoms that the physicians oftentimes want to assess, and it's often contraindicated in patients that are hypotensive. For this reason, you should always reach out to medical control before administering any kind of pain medication interventions on your way to the hospital. An evisceration is when the abdominal organs protrude through a wound in the abdominal wall. Of course, we're never going to try to tuck the organs back into the body, and we're not going to use any material that will stick to the abdominal organs. What we want to do is we want to apply some saline-soaked sterile dressings, get the dressings wet before you apply them, and place them over the top of those eviscerated organs, and then we can cover that area to try to keep it warm. The goal is to keep it warm and moist. And then we're going to transport the patient to the closest hospital immediately. When the abdominal wall cuts off blood flow to the protruding bowel, it is called strangulation. And early symptoms are going to include localized pain, maybe some nausea or vomiting. Peritonitis can also occur if the bowel is leaking into the abdominal cavity, and the patients may feel more comfortable with their knees bent. You should discourage the patient from coughing or bearing down, and consider providing pain relief when necessary and with consultation from medical control. Impaled objects, of course, the first rule is to stabilize that object and never attempt to remove it or manipulate it in any way. You should transport the patient in the position in which you found them. In unusual situations, it may be necessary to shorten a portion of the object while it is still in the abdominal cavity. In these cases, make every attempt to move the object as little as possible and keep it as stable as possible, and that way you don't cause additional injuries. Okay, so the pathophysiology, abdominal trauma can be life-threatening because injuries can bleed profusely, and they can hold a large amount of blood internally, as we've discussed. Injuries to hollow organs also carry a serious risk of infection. The main causes of death from abdominal trauma are hemorrhage and systemic infection. Diaphragm injuries are rare but can result from both blunt and penetrating trauma. Signs and symptoms of this type of injury are related to breathing problems or ventilatory compromise, and those are going to be your key indicators that you may have a diaphragm injury when you have an abdominal injury. These injuries are not isolated. They're almost always associated with other injuries to the chest, abdomen, head, and extremities, and they just further complicate an already messy trauma patient. Solid abdominal organs include the liver, spleen, kidneys, and pancreas. An injury to any one of these organs can cause blood to be released into the peritoneal cavity, which may result in non-specific signs such as tachycardia and hypotension. The findings of these injuries are related to the size of the injury and the time since it occurred. The liver is the largest and most vascular organ of the abdominal cavity, making it the most vulnerable organ in the abdomen. You should suspect a liver injury in a patient with trauma to the right side of their chest or to their upper right abdomen. In incidents involving sudden deceleration, the ligamentum teres, which is the ligament in front of the liver that holds it in place, can actually slice the organ in two. An injury to the liver can be a contusion, a laceration, or a hematoma. Any of those can develop from an injury to the liver. A patient with liver injury may present with a history of the following signs and symptoms: injuries to the upper right or the central abdomen, injuries to the right lower chest, including fractures of the ribs and of the right lower ribs, bruising and tenderness to the right upper quadrant, abdominal wall spasms, rigidity, involuntary guarding, and rebound tenderness, and hypotension or signs of hypovolemic shock. The spleen can be injured by falls and motor vehicle crashes, as well as by less obvious trauma like sports injuries. Ruptures have been reported from minor contact, especially if the spleen is enlarged from an underlying disease or something along the lines of mononucleosis. If the spleen ruptures, it can bleed profusely, causing blood to spill into the peritoneum, which can lead to shock and death. Penetrating trauma to the spleen is not much of a threat for shock unless a major blood vessel supplying the spleen has been lacerated. You should suspect a spleen laceration if the patient has any of the following signs: fractures of the 9th and 10th ribs, tenderness to the upper left quadrant, signs of peritoneal irritation, referred pain to the left shoulder known as Kerr's sign, and hypotension or other signs of hypovolemic shock. Hollow abdominal organs include the small and large intestines, stomach, bladder, and injuries to them produce symptoms of peritoneal contamination. A seatbelt sign, which is a bruise or abrasion across the lower abdomen, usually indicates an injury to the organs inside the peritoneum. Blunt trauma to the abdominal walls from a seatbelt commonly causes an injury to the duodenum, which may present as back pain. Injuries to the small and large intestines most commonly occur from penetrating trauma, and a rupture will cause peritonitis. Penetrating trauma most often injures the small bowel, stomach, and large intestine, and the symptoms are caused by the contents spilling out rather than the blood loss that we might associate with those injuries. An injury to the small bowel or colon may present with only generalized pain. Stomach injuries most commonly result from penetrating trauma. However, a stomach rupture from blunt trauma is usually associated with a recent meal or the improper use of a seatbelt. When the stomach is injured, acetic material spills out, causing abdominal pain and peritoneal signs. Be aware that acetic antacid medications may delay the onset of these symptoms, so getting a good sample history may help you understand why they're not showing the symptoms you might suspect. The retroperitoneal cavity holds the pancreas, kidneys, major blood vessels, and part of the small intestine. Because of this, injuries to the area do not typically present with signs and symptoms of peritonitis, abdominal pain, and abdominal distension. Occasionally, bleeding in this area can lead to a Gray-Turner sign or a Cullen sign, which is bruising around the belly button. A Gray-Turner sign is bruising in the flanks, and Cullen sign is a bruise around the umbilicus or a bruise around the belly button. Because the pancreas is well protected in the retroperitoneum, high energy forces, most often penetrating trauma, are needed to cause an injury to the pancreas. When the pancreas is injured, it releases enzymes into the peritoneum that irritate and start to break down internal organs and tissues. The process is called autodigestion. This enzymatic breakdown leads to chemical peritonitis, and the findings may be significantly delayed because it does take time for those pancreatic enzymes to begin to do their work. The retroperitoneal space contains many important vascular structures, including the kidneys, descending aorta, inferior vena cava, the superior and inferior phrenic and mesenteric arteries. While penetrating trauma is the most common injury, blunt trauma can also cause vascular structures to be torn from their points of attachments. Compression or deceleration forces applied to the abdomen can cause small vessels to tear away, which can result in fatal bleeding or exsanguination. A tear in the vessel's inner lining can also occur, which may lead to the formation of blood clots inside of the vessels. The duodenum can rupture in cases of high-speed deceleration injuries, causing its contents to spill in the retroperitoneum. This contamination can cause abdominal pain and fever. but be aware that these symptoms may be delayed for hours or even days following the traumatic event. You should maintain a high degree of suspicion of duodenal injury in any abdominal trauma, as it is unlikely to be the only injury due to its proximity to other organs. Be particularly suspicious of duodenal injury in children who have been thrown from a bicycle and strike the handlebars. Kidney and uterine injuries can occur alongside other abdominal trauma and are generally caused by large forces from events like falls, high-speed motor vehicle crashes, and contact sports. You should suspect kidney injury if the patient has fractures to their 11th or 12th ribs or tenderness in the flank. Blunt kidney trauma can result from the kidneys being compressed against the lower ribs or lumbar spine, which as with a kidney punch in sports, such as with a kidney punch in sports. Most renal injuries are caused by contact sports. A ruptured kidney presents with pain in the abdomen and flank areas when the patient breathes in, as well as gross hematuria, which is that visible blood in the urine. Penetrating renal trauma from gunshots or stab wounds to the abdomen or lower chest should be treated with a high suspicion of significant injury. This type of trauma is likely to be associated with injuries to the liver, lung, and spleen as well. Urethral injuries are very difficult, if not impossible, to identify in the pre-hospital setting. They rarely lead to immediate life-threatening conditions, but they can be problematic on down the road. Bladder and urethral injuries are typically associated with other significant injuries. An injury can result in a bladder rupture or laceration. These injuries are usually associated with pelvic injuries from motor vehicle crashes, falls from heights, or physical assaults, and pelvic fractures may perforate the bladder. A bladder rupture is associated with a high mortality rate because the trauma required to pierce it often damages other organs and major blood vessels in the area. When the bladder ruptures, urine may spill into either part of the abdominal cavity, leading to an intraperitoneal, extraperitoneal, and retroperitoneal rupture. Signs and symptoms of a bladder rupture can include gross hematuria, subpubic pain and tenderness, difficulty urinating, and abdominal distension, guarding, as well as rebound tenderness. Signs of internal bleeding may not develop until a significant volume of blood has been lost. Because of this, normal vital signs do not rule out an internal abdominal injury. Bleeding can cause abdominal tenderness or distension, but these same signs may not be obvious until a significant amount of blood has been lost. Palpation may reveal localized or generalized tenderness, maybe some rigidity, or even rebound tenderness, but sometimes the signs are not real specific. Pancreatic injuries often have subtle or even absent signs, so you should have a high index of suspicion for them as well. Suspect an injury after a rapid deceleration or localized blow to the mid-abdomen. Patients often report vague pain to the upper and mid-abdomen that radiates to the back. Be aware that peritoneal signs may not develop until hours after the injury. The findings of a vascular injury depend on whether the bleeding is contained or actively hemorrhaging. In an active hemorrhage, the patient's presentation will include hypotension, tachycardia, and shock, just like we would expect it to. Blunt kidney trauma often presents as flank pain and hematuria. You should have a high index of suspicion of kidney injury if the patient has bruising over their upper abdomen, the sides of their middle back, or over their lower rib cage. Fractures of the lower rib cage should also raise your suspicion. You should suspect a bladder injury if the patient has any of the following: trauma to the lower abdomen or pelvis, the inability to urinate, blood in the urine, tenderness upon palpation of the suprapubic region, or if there's an ultrasonography that has been used in the field with increasing frequency, this ultrasound can actually help kind of pinpoint whether or not there is a bladder injury. You should maintain a high index of suspicion for internal abdominal damage whenever the mechanism of injury suggests it. Patient management is going to include supporting ABCs, restricting spinal movement as needed, performing that rapid patient evaluation, and transporting them to an appropriate receiving facility, as well as monitoring the patient's vital signs and their overall condition for changes that may be coming, that may be happening. The big thing to remember with abdominal injuries is they can be so subtle and hidden for such a length of time that oftentimes the patients may feel okay. But if you have a high index of suspicion that there's an abdominal injury, it's important you convince them not only to go to the hospital, but that you transport them to a facility that's going to be capable of managing them quickly. Because while you're transporting them to the hospital, their condition may deteriorate. They may at the scene tell you they don't want to go to the hospital and want to try to refuse care, but it could turn around for them pretty quickly. All right, so the male genitalia, when we're dealing with injuries there, remember again, rarely are these injuries life-threatening, but they do need to be addressed because they can be the source of a significant amount of blood loss. The major concern with injuries to the testes or scrotal sac is the potential for a loss of fertility. We're trying to preserve, them being able to reproduce. Blunt trauma from events like motor vehicle crashes, physical assaults, or sports can result in contusions, ruptures, and testicular torsions. These injuries frequently present following trauma to the thighs, buttocks, groin area, lower abdomen, and pelvis. Penetrating trauma to this area can be caused by stab wounds, gunshot wounds, blast wounds, and even animal bites. Penile injuries can result from blunt or penetrating trauma, accidents during sexual behavior, and even self-mutilations. But remember, priapism, which is a prolonged erection, can have a non-traumatic cause, such as from sickle cell anemia or an adverse medication reaction as well. Remember, a priapism in and of itself doesn't necessarily mean that there's an injury to the genital urinary area. It could be more systemic, or it could be a spinal injury. A fractured penis may occur when an erect penis is impacted against a pubic bone, or it's bent too far one way or another. Who knows how these things happen? And of course, penetrating trauma to the penis is often caused by gunshot wounds and stab wounds, but typically it's gunshot wounds that we see those. Contusions to the area result in painful hematomas that may respond to ice packs. A testicular rupture is often difficult to identify, but a presenting complaint is typically tender or swollen scrotum. Torsion is also very difficult to identify in the field. While serious testicular injuries are rare, internal bleeding in the scrotum doesn't require much force in order to make it bleed. If there's when we're dealing with a penile fracture, it is a tear in the wall of the corpora cavernosa, which presents with severe pain and a large hematoma. Penetrating trauma occurs, you must first control the hemorrhage and then assess the patient for other injuries. When treating hemorrhage or testicular evisceration, apply gentle compression and ice packs. You should also provide pain reliever and emotional support when appropriate and when you can. If bacteria enters the scrotum from a laceration, it can result in foreigner gangrene, which causes necrosis of the muscle and subcutaneous tissues. Signs and symptoms include a spongy, crackling sensation, like a crepitus sensation in the scrotum, maybe some gray-black scrotal tissue. wound drainage, fever, and pain. This is a true medical emergency that requires prompt transport to the hospital, as leaving it untreated can lead to systemic sepsis. An amputated penis can actually be surgically repaired, so you should attempt to recover the amputated part and transport them quickly to a hospital that is capable of reconnecting. If an object is placed around the penis or testes, do not attempt to remove it. Instead, transport the patient to the hospital for evaluation and treatment. Sometimes they get things wrapped around that stuff. All right, let's talk about female genitalia. Blunt trauma can result from high energy motor vehicle crashes or saddle type injuries. This type of trauma can cause lacerations to the vaginal wall, the uterine rupture, or even ovarian contusions. Trauma to the external genitalia may also produce contusions, bruising to those areas as well. Penetrating trauma can be caused by stabbings to the lower pelvis or even gunshot wounds. Self-inflicted trauma can also occur when foreign bodies are inserted into places where they shouldn't be. Signs of trauma to the external female genitalia and lower pelvic area can include hematomas, bruising, bleeding, and tenderness upon palpation. Your assessment may also reveal clues that may be tied to a potential sexual assault. Use compression to control any external bleeding. Administer replacement fluids to treat hypotensive patients, but use pain medications with extreme caution. Do not attempt to remove any object that is lodged in the vaginal canal. Instead, transport the patient to the hospital for evaluation and treatment. Be sensitive to the emotional needs of the patient and be familiar with your local reporting requirements as it relates to sexual assault cases. All right, and there we go. There you have it. Abdominal and genitourinary injuries are all covered. So that's it for chapter 37. See you back at chapter 38.